Sorry for this technical. So this is the venous drainage of the brain, showing the main venous sinus and showing the deep sinus system, then some cortical veins. Probably the transverse sinus is the most common place for thrombosis, but keep in your mind those little ones, the cortical veins that present with thrombosis in a very unusual way. If you see a patient coming with severe headache and papilledema, always keep in your mind cerebral venous thrombosis, and you need to look at the cerebral venogram to confirm the diagnosis, especially if the patient has underlying risk factors such as birth control pills, malignancy, or the patient is postpartum. Our group, Dr. Fahmi Sinani and Dr. Naeem published a while ago the prevalence of cerebral venous thrombosis, and they looked at different aspects related to CVT, and still headache and seizures being the most common presentations. And they found that most female patients have had used OCP. However, the most CVTs had a good prognosis. You know all this huge list. Sorry about the table, probably small letters, but it's just a refreshing slide. And CVT has similar causes in comparison to the systemic thrombosis. But there is a specific phenomena that we observed happened in Ramadan. Dr.sheef and his group and KFMC published about this, looking at the prevalence of cerebral venous thrombosis during Ramadan, since there is a culture or attitude in Ramadan of increasing OCP use, in order to fast in the holy month of Ramadan. And when they found that the prevalence, the incidence goes up during Ramadan, and about 40% of CVTs have used or newly user of OCP. And the CVT was mostly driven by two factors, being or having protein S deficiency and dehydration as a provoking factor. Transverse sinus remains the most common place as shown in the study, and similarly found in most of the studies published about CVTs too. I would like to share a few cases with you, just to show you uncommon causes of cerebral venous thrombosis. The first case is 55-year-old male patient came from jail with bad headaches, and his CT scan showed hemorrhage in the right temporal area. And his cerebral venogram showed or confirmed transverse sinus thrombosis. But during examination, he was noted to have disseminated skin lesions, quite similar to scabies. So that raised alarm about possible underlying immune deficiency. Then HIV testing came back positive. And this has been known about CVT, and HIV been added as a cause of cerebral venous thrombosis. Or CVT could be a primary presentation of HIV infection. The second case, probably it's mostly medical, and you would guess what the diagnosis is. 27-year-old female with severe headaches came with change in the urine color and found to have non-immune hemolytic anemia. Her MR venogram, as shown here, with venous thrombosis of the right transverse sinus, and having thrombosis, change in the urine color, hemolytic anemia of non-immune type, it was felt to be a possible of PNH, and then flow cytometry confirmed the diagnosis. And this is her first presentation at this age of thrombosis within the brain. So always keep your mind and link the information, the clinical and laboratory information together in order to reach the diagnosis. The last case that we published about recently of a sickle cell disease patient, known to have sickle cell, but never had a crisis in his life. he presented with cerebral venous thrombosis as his first vaso-occlusive crisis in his life. And he did well. He presented with massive hemorrhage and found to have venous thrombosis on the imaging. He had exchange, and he did well later on after rehabilitation. So keep in your mind that sickle cell disease in the list of cerebral venous thrombosis, and could be the first presentation of an occlusive crisis in those population. Imaging-wise, CVT could present in different ways. It depends on the location of the thrombosis and the timing of a presentation to the emergency department. Findings range from just simply intracerebral hemorrhage, could be involving the deep system, causing bilateral hypodensities in the brain, like this one in both thalami, or having a hyperdense vessel, quite similar to what we see in the arterial system. Another way of a presentation of cerebral venous thrombosis is a presence of hypodensity bilaterally that does not correlate with the arterial territory. So always keep in your mind the possibility of CVT, and it may look like a tumor as well. So venogram or MR imaging will help in differentiating. There is a unique presentation of CVT. It's called non-aneurysmal cortical cerebral venous thrombosis, subarachnoid hemorrhage. It has a unique differential diagnosis, but CVT is one of the most common presentation of this type of subarachnoid bleed. Then at the end of the day, you need to confirm the diagnosis with either CT venogram or MR venogram. Probably MR adds more information related to the extent of ischemic changes, location of the thrombosis or burden of the thrombosis, and it helps you to identify the venous infarction and whether there is another etiology underlying the thrombosis, like infection, metastasis, or others. We always get asked about utility of D-dimer. We don't do most of the time because it is debatable whether it is helpful in diagnosis of CVT or confirming cerebral venous thrombosis. It has issues related to timing of doing the test and the burden of the thrombosis. For example, you may get a negative D-dimer or low D-dimer because the test was done away from the time of thrombosis, or because the burden of the thrombus was too small to provoke a significant D-dimer level. So it's maybe a test that add on, but not really important for us in neurology. So our second part is the therapeutic options related to cerebral venous thrombosis, and we use exactly the same strategies that been used with systemic thrombosis. In the acute phase, anticoagulation, there is a maintenance phase, again with anticoagulation, but duration, it depends on the cause of the cerebral venous thrombosis. Then we look at the complication of cerebral venous thrombosis. The thrombectomy comes in the acute phase and been growing lately because of availability of technology and the success that has been seen in the ischemic stroke thrombectomies. So this is just a slide showing different studies telling us that anticoagulation is helpful in cerebral venous thrombosis. We always get this question about the risk of hemorrhage expansion when patients with CVT or presenting with hemorrhage in the brain. no matter what the imaging is telling you, you have to put the patient on anticoagulation, even if there is hemorrhage in the brain. Several studies showed safety, and there is no expansion of the hemorrhage. In fact, anticoagulation will reduce the risk of rebleeding or expansion of thrombosis or expansion of the hemorrhage, because anticoagulation will stabilize the thrombus and hence will reduce the congestion in the brain. The second question that always entertained among the teams, whether we use unfractionated heparin or low molecular weight heparin, just because we are worried about the expansion of the hemorrhage. Studies showed that, in fact, enoxaparin has lower rate of a thrombotic complication, lower rate of major hemorrhages, mortality, or recurrence of thrombosis, and in fact has higher rate of reduction of thrombus size and better recanalization. And I have my own experience. I always use enoxaparin in CVTs in acute phase, regardless whether there is hemorrhage or no hemorrhage. However, there are two schools of thoughts among neurologists. Some like to use this approach. If you see here on the right, if you see hemorrhage in the CT scan, they will go for unfractionated heparin. So, and they follow the patient. If there is any hemorrhage expansion, they may just turn off the unfractionated heparin and reverse it. Patient has no hemorrhage, they go with enoxaparin. So this is just a simple approach, probably safe for some people who are worried about hemorrhagic expansion. DOAC as business as usual. DOAC, you know, dabigatran was proved to be effective in reducing cerebral venous thrombosis risk of recurrence. Similarly effective to warfarin and cerebral venous thrombosis. Similarly for other DOACs as well in other small studies. But the worry about DOAC is using them for hereditary thrombophilia or high-risk thrombophilia, or in cases of antiphospholipid syndrome. I mean, it is quite debatable from our perspective. I know you guys in thrombosis team probably has more experience in using DOACs and high-risk thrombophilia. But still, warfarin would be the best option for such high-risk population, unless there are contraindications or caveats from using warfarin. The duration of therapy, again, we learned this from you guys, thrombosis colleagues. We use the same approach of using up to 6 months in a provoked population, up to 12 months of unprovoked population, probably in high-risk patients will go with indefinite anticoagulation. The next few slides, I will talk about thrombectomy, how thrombectomy will help the venous system. As I mentioned earlier, that thrombectomy has been successful in large arterial thrombosis. And you know about stroke codes business and KFMC and how often we have done thrombectomy, and there's a great team over there dealing with such a procedure. They have experience too. Can we apply the same business on the venous system? I would like to share this case with you first before talking about the literature. This is I had a case in stroke code, a 55-year-old presented with ataxia and drowsiness, and his CT of the brain showed hypodensity in the thalami, where he raised a suspicion of deep venous thrombosis. CT venogram, this is a venogram showing superior sagittal sinus with good contrast filling. But if you go down here, you lose the signal, or you lose the contrastation among the straight sinus and the deep veins, indicating thrombosis. This patient presented in the night. In the morning, he was almost semi-comatose. This type of thrombosis is really bad and has high or bad prognosis. So we had a call for help. We put him in anticoagulated, then we called the intervention. Intervention team was hesitant at the beginning because this area is difficult to access, and it does not usually get into a good prognosis. Plus, there are deep venous system involvement. But there is a great team in KFMC. They were very courageous. They went in and they were able to recanalize this area of the straight sinus and some of the deep veins. The patient had a slow course in the hospital. We kept him in anticoagulation, but surprisingly and amazingly, he improved. And I received a call from the family just last month saying he's able to ambulate, moving, talking. He just left over with some memory difficulties and sleep impairments. This is considered amazing and impressive results for deep venous thrombosis. So it has a role in this systemic review, shown some benefits of thrombectomy in venous system. It is safe. As you could see here, there is a good percentage of recanalization, despite not much of complete neurological recovery, but this is considered significant. A third of them, they had good recovery. Probably those patients and those trials been or had bad or severe cerebral venous thrombosis forms. That's why you see good recanalization, but not equivalent amount of neurological recovery. However, I mean, there's no new worsening, not too much of worsening hemorrhage, and severity recurrence was quite low. So when we should call our colleagues from intervention, thrombectomy is good. It's can be utilized as rescue therapy for those patients. Probably we need to call them if you see your patient continuously deteriorating despite anticoagulation within the next like 48 hours. Probably thrombectomy would be a great option for patients who are not qualified for anticoagulation for some reasons, for example, massive GI bleeding. Probably consider early thrombectomy for patients presenting with extensive thrombus burden before they deteriorate. And we have a plug and play mechanism, how we can approach CVT in general. So if you have a cerebral venous thrombosis case or suspected case in the emergency department, you really need to confirm the diagnosis either with CT venogram or MR venogram. As I mentioned earlier, MRI would be better because it tells you more information, but CTV is quite good, especially in ED setting. Once you exclude other conditions and you confirm cerebral venous thrombosis, your best bet is anticoagulation right away without a delay. We always tell our residents that to send thrombophilia workup before initiating heparin, since heparin may affect some tests. So that keep that in your mind. Thrombosis itself and heparin as well may impact the result of those tests. But anyway, we always try to send the labs before initiating heparin. Then if the patient gets better, then you go with a long-term plan of anticoagulation. It depends on the etiology and the underlying mechanism. Then if the patient starts to deteriorate in the emergency department or during admission, please consider intervention and thrombectomy because the early deterioration indicates aggressive type of thrombosis. So aggressive disease needs aggressive treatment. So think about thrombectomies and then surgeries in case of patients requiring a decompressive procedure for a massive venous infarction. Complications wise, you know that those patients, most of those patients end up with issues after CVTs. Change in the headache pattern, they get migraines, some of them they get seizures, We have seen tons of cases. They present with increased intracranial pressure and papilledema in chronic phases as well. So keep those in your mind as potential complication of cerebral venous thrombosis. What is the prognosis out of this? We always reassure our patients that there is a high chance of recanalization without doing anything. And the risk of CVT recurrence is almost 1 to 2%, unless the patient has very high risk of thrombophilies. However, the risk of any thrombosis in general after CVT would be up to 6%. A study published in Stroke, they looked at different factors that may predict poor prognosis after cerebral venous thrombosis. Probably if you have a male patient presenting with a very bad level of consciousness, deteriorating rapidly with underlying malignancy, those people usually have bad prognosis compared to others. They listed different factors that may help you in prognosticating patients early on, although those factors won't change your approach to management. So the take-home message, it's important to recognize CVT despite anticoagulation as being the most important treatment for all patients. Keep thrombectomy in your mind. It is safe. It can be helpful. It's better to get interventional team involved early on in a similar way to the arterial occlusive diseases. Treatment strategies are variable, depends on the nature of thrombosis, underlying cause, or provoking factors. DOAC is playing a role, and its role is growing. And we have been using it a lot lately in cerebral venous thrombosis with good safety profile. And generally reassure your patient about the prognosis. And most patients need follow-up, since they have risk of complications that can be treated as well. So thank you. I'm going to stop here, and I'm happy to receive any questions.